So, Dr. Yo, I'll let you touch on Rantes.
Yeah, that's great. It's a good segue into probably the one topic that I get emails and text messages. My Instagram is blown up, so everyone, thank you for reaching out to me. And the topic is Leronlimab, Rantes, and Dr. Patterson's study. Dr. Mike and I, we talked a little bit about Leronlimab and Rantes last week in our live video, so you guys can go check that out. I made a video on Leronlimab. I also just posted a couple of days ago the actual mechanism, a stripped down version of what is going on with Leronlimab and COVID-19. Now, with that being said, probably my next video is going to be on Rantes. And I will sort of tell you a little bit about how I started to get really interested in it. About 2 weeks ago, Dr. Patterson, in his from Cytodyn, he's the Incel DX virologist, someone whose work I've been digging into and just have a lot of respect for, came out and said that COVID-19 was a Rantes disease. And what that means is we know that we know what COVID-19, it's a virus. We know that mostly it's pretty much we can say that it is a respiratory virus, and that's the entry into the body. So it's a respiratory entry point, and that means to the mouth, nose, and eyes. But the early part of the disease, if you guys look at this last video I posted where I talk about sort of the pathogenesis or a timeline, the first, you have infection, and after infections, I don't want to say most, but a lot of people are asymptomatic. They're not showing any symptoms, but they still have the virus in them, means they're infected, they can shed and spread the virus. If you guys are basketball fans, you might know that Kevin Durant and Donovan Mitchell, Donovan Mitchell plays for the Utah Jazz, and Kevin Durant plays for the now the Brooklyn Nets. And it was interesting. They got on Twitter and they said the scariest thing about this disease is we didn't know we had the virus. The NBA did these testing. They were just sitting there playing video games and hanging out. So there's a big chunk of the population that are getting exposed and are asymptomatic. And they're still considered infected. And then another group of people will go to what I call is the early phase, and that's probably the first 7 to 10 days. And that's when the antivirals are believed to have the most effect. Like remdesivir, if you look at the studies, usually their effect is in the first 5 days. After day 5, actually, interesting enough, placebo has effect than remdesivir. So you have to target those patients in the first couple of days for a medication like remdesivir, potentially even hydroxychloroquine if you want to add zinc or quercetin or azithromycin. They should be targeted early. I mean, that is really the suggestion. There's a lot of studies that are going into that to seeing exactly what the timeline is. But as the disease progresses and as your immune system gets fired up, we start developing the cytokine storms. And this is when the antivirals it's the virus itself is not really doing much, and it's the cytokines that are really taking over. And so what the cytokines are, it's like a revved up immune system. One of the major cytokines that have been studied extensively is interleukin-6. As I mentioned in my video, cytokines are like messengers. That's how the system communicates with each other. So we've been thinking it's interleukin-6, interleukin-1, tumor necrosis factor. And it's really interesting that Dr. Patterson talked about in his study, he just put an abstract out looking at the 10 patients at Montefiore Hospital, that it is a Rantes disease. And Rantes is a chemokine. And as Dr. Mike just suggested, it's like a perfume. So if you think about you're in one corner of a room, and you have someone there and they've got a heavy cologne or perfume, and you got someone else that is blindfolded, and you ask them to go closer to the person with the perfume, the stronger the closer they get to that person, the stronger the perfume is. But imagine now you put like clamps on your nose. Well, the person that's blindfolded is not going to know where the person with the perfume anymore. They're just either going to stay there or go somewhere else. And that's really what leronlimab is doing. Because if this is truly a Rantes disease, like Dr. Patterson is suggesting and showing in his paper, then by blocking the Rantes CCR5 receptor, and so the Rantes and CCR5, that's the receptor, that complex, by blocking, or really the more correct term is by occupying that receptor, you are sort of mitigating that response. So all the other immune cells cannot come to the area of to worsen up the cytokine storm, and you can redirect those immune cells to go fight the virus. And that's why I'm a firm believer this is a cytokine disease rather than a viral disease. I know, that might sound a little confusing because you're going, well, this is a virus causing it. Yes, but what's making this, in my opinion, I believe the severe symptoms and why people are succumbing to the disease is the cytokine storms. And a lot of physicians, I believe, are not appreciating how serious cytokines are playing in the pathogenesis of this disease. And by quickly identifying when patients are able to getting into a cytokine storm, and start treating with these monoclonal antibodies like Leronlimab or Tazozulumab or Saralumab, the patients could potentially have a better outcome. So that's a little bit about Rantes. I'm going to dive in a little bit more this week in a video where I'm going to go into kind of research and all these discussions about Rantes over the past couple of years. Rantes has been studied extensively for the past 20 years with HIV. So it's a chemokine we already know. What is also interesting enough is with Leronlimab is that it is a cancer. Is actually used to treat breast and prostate metastasis. There are other cancers it has an effect for, but with breast and prostate cancer, it is having the outcomes are great. I've actually sent Leronlimab information to a couple of my hem-onc friends, a couple of my internal medicine friends. They've all come back to me saying, Ram, this medicine actually has a benefit for in our cancer patients. One of my colleagues, an old friend of mine from high school, she's an oncologist in the Orlando area. She's so excited to trial this on her hem-onc patients, for her breast cancer patients. She sees 90% of the patients she sees are breast cancer in her practice. We are working with another patient on getting Leronlimab trial for her breast cancer. I'll keep you guys posted if on those stories. So it is showing a lot of promise. And like Dr. Mike and I have talked about, we don't have any relation with this company. We're not getting paid by them. We don't know anyone from the company. They've been great in terms of giving us information, looking over some of the studies. So this is just something we have independently looked at. I've had my physician friends also independently look at some of this data. Now, with that being said, there are no, with COVID-19 and Leronlimab, there are no randomized control trials right now. There's this 10-person Montefiore study, and I know out in UCLA, Dr. Otto Yang is doing some really incredible research out there. And so I just want to share with you guys, Dr. Yang, I was on a conference call a couple of days ago, a UCLA conference call where they made a presentation about all the research, and he sort of focused a lot of his research on, or his discussion on Leronlimab. And I'm just going to share with you a slide that, and I think this will be up on the UCLA website. I can find the link to it and have you guys listen to this conference call. But he looked at the Leronlimab first 5 UCLA patients with moderate disease. And what was really interesting is with the C-reactive protein, which Dr. Mike has talked about extensively. It's an inflammatory marker. A high level is a poor prognostic indicator. And of these 5 patients, the C-reactive protein at about day 2, 4 out of the 5 patients started to see a decrease by day 2. Actually, I take it back, by day 1. So you see some improvements in CRP in 4 out of the 5 patients. Now, in looking at a blood total lymphocyte count, as Dr. Mike mentioned about the CD4 and CD8, the ratios could be decreased. There's some sort of immunosuppression that's taking place with COVID-19. And one of the low levels of total lymphocytes is a poor prognostic indicator. And according to Dr. Yang, the slide that he published or he showed at his news conference, by day 2, 4 out of the 5 patients again showed a decrease in their T lymphocytes. So you're starting not only the Montefiore study, but you're also seeing it from some of the early data from the UCLA study. So this is why I've been really excited about the potential for leronlimab. I know I've been talking about it with Dr. Mike, and I think he's as we talk about the data and we start looking at things, I think Dr. Mike is starting to see some of the potential and the excitement I've had. One of the things I noticed with my patients was they were not responding to hydroxychloroquine or remdesivir. It's what do we need something for late stage COVID-19. And I'm not saying leronlimab is the game changer. I'm not saying it's the magic drug, but it might be worth for a lot of physicians in this country, a lot of hospitals, to consider looking at it instead of the status quo, which is quite honestly not working.